Welcome to a video on pupil examinations, part 3 of DIY eye exams. The pupil is not a real anatomical structure, but rather a hole in the center of the iris. To examine the pupil, we use the acronym PERLA, P-E-R-R-L-A. PERLA stands for Pupils Equal and Round, Reactive to Light and Accommodation. Before we look at the exam, let's first understand the anatomical elements involved in the pupillary light reflex. There are two parts to the pupillary light reflex. Firstly, the blue afferent pathway brings information from the eye to the brain. The red efferent pathway sends that information from the brain to the pupils. The afferent pathway consists of the retina, optic nerve, optic chiasm, optic tract, and pretectal nucleus in the midbrain. The efferent pathway consists of the pretectal nucleus in the midbrain. This sends information bilaterally to both sides, traveling along both oculomotor nerves. That's the third cranial nerve. This travels to the ciliary ganglion and finally causing the pupillary muscles to constrict the pupil. Now that we understand the pupillary reflex pathway, let's have a look at pupil examination, PERLA. First, we observe the pupils to see if they are equal and round. We do this in both bright illumination, where the pupils are smaller, and dim illumination, where the pupils are larger. This is because if the unequal pupils, otherwise known as anisocoria, is worse in the light versus the dark, there may be different causes. Anisocoria in the light is due to a failure in the pupil to constrict. The parasympathetic pathway is responsible for constriction of the pupils, and damage to the parasympathetic pathway may be caused by the 4 T's: trauma, tropicamide or other similar pharmacological agents, third nerve palsy, and tonic pupil. On the other hand, anisocoria in the dark is due to a failure in the pupil to dilate. The sympathetic pathway is responsible for dilation of the pupils, and damage to the sympathetic pathway may be caused by the Horner syndrome, pilocarpine, or other similar pharmacological agents, and adhesions of the iris. The next step in our examination is testing if the pupils are reactive to light. We test pupillary light reflexes by looking for both a direct pupil constriction reflex and also a consensual pupil constriction reflex in the other eye. The consensual pupil constriction is due to the double decussation in the pupillary light reflex pathway. Now shine the pen torch in each eye for 2 seconds before moving to the opposing eye, moving the pen torch below the patient's line of sight. Note that when we swing the torch between each eye, both eyes stay constricted. Ensure the pen torch is being shone from the side whilst the patient is looking into the distance. As we understand the visual pathway for the pupillary light reflex, we can pick up lesions in this visual pathway, especially those in cranial nerve 2 and 3. An important defect to pick up is called the relative afferent pupillary defect, otherwise known as RAPD, or also known as a Marcus gun pupil. This is where the afferent pathway is damaged partially or completely. In this patient, the RAPD is caused by severe optic neuritis in their left optic nerve. If the afferent limb is damaged, both eyes will still constrict well when light is shone into the healthy side. But when we swing our pen torch over to the affected side, the pupils will not constrict well, and even seem to dilate relative to before. As we observe the abnormal side dilating, this is called a direct RAPD. Now let's see what this looks like when we swing back to the healthy side. As we swing the light into the right eye, the healthy eye, both pupils constrict well. There is both a direct and consensual response. For our swinging torch test, we always perform it a couple times to confirm the diagnosis of a RAPD. So let's have another look. Here the pupils constrict normally. As we swing across, Notice the direct RAPD as the pupil of the abnormal eye dilates. As we swing back to the healthy eye, notice how the pupils constrict normally. Now what we've just seen is an example of a severe RAPD, where both pupils look larger before possibly constricting minimally when the affected eye is illuminated. However, note that in less severe cases, like this one, the dilation may be less obvious, and the only evidence of a RAPD is the slightly delayed pupil response. Now to test your knowledge. In which eye would the pupillary light reflex still be present if the right oculomotor nerve was compressed? Pause the video here before we reveal the answer. How did you go? The oculomotor nerve is part of the efferent pathway. As a result, the right pupil on the same ipsilateral side will not constrict, regardless of which eye is illuminated. Note the anisocoria caused by a third nerve palsy as the eyes are illuminated. On the other hand, the left eye will not be affected, constricting when either eye is illuminated. Therefore, only the affected side will have absent pupil reflexes. The final part of our pupil examination is testing if the pupils are reactive to accommodation. To do this, we hold up the patient's own finger 10 centimeters from the patient's eyes. As they focus on the finger, we should see their pupils constrict. On the other hand, lightning dissociation is observed if the pupillary light reflex is impaired, but the near pupillary accommodation reflex is still intact. This may be caused by pathologies such as a midbrain pathology, tonic pupil, RAPD, third nerve palsy, or ocular trauma. Now try this on a friend. Follow the steps per law. Pupils equal and round, reactive to light and accommodation. Each step of the exam is important, as omission may mean you miss a subtle clue of pupil pathology, and sometimes the only sign of a sinister disease. You could even save someone's life. Thanks for watching part 3 of DIY eye exams.